would like to thank the organizers, masterclass of lung cancer, as well as Prof. Raghu Thota for giving me this opportunity to present this topic, which is kyphoplasty and intrathecal drug delivery system. So first of all, kyphoplasty, basically the indication is very simple: single or multiple vertebral wedge fracture, anything from cervical, dorsal spine, lumbar spine, you can perform this procedure. Also indicated for metastatic painful lesion in the spine, for painful hemangioma, and whenever as a part of the multimodal treatment, if the patient's pain is not relieved with opioids, we perform these procedures. The contraindications are usual, like uncorrected coagulation disorders, if the patient is having local infections, patient refusal, and other things. Apart from there is a difference between vertebroplasty and kyphoplasty. If there is a leak in the posterior cortex, we prefer to do the kyphoplasty rather than vertebroplasty because of the cement leakage. The procedure, there are different equipments, there are different sets which are available, anything from Korean company, from German company, as well as from Medtronic. We are using this procedure with Medtronic system, and it has to be done under C-arm. Usually we take a informed consent of routine complications like infection, bleeding, nerve damage, partial relief, increased pain. But apart from that, we usually take a consent of pulmonary embolism because of the leakage of maybe cement into the epidural space, epidural abscess, also risk of paraplegia because of these procedures. And in my center, we also take a rare possibility of even death during performing all these things, because we have to be very, very safe and in terms of medical legal. So this is a set you can see here. I mean, this is a inflatable device. This is balloon. These are different needles like Jamshedi needle, as well as this is trocar or stellate. And then the drilling system, this is the driller. And later on, for the introduction of the cement, these are the different channels. Okay. I use this procedure under very mild sedation. Usually we give 1 gram of paracetamol or maybe 6 milligram of morphine. But in my practice, I don't perform under anesthesia or even with midazolam, because the patient's coordination with the operating physician is very important. The position is prone position. We usually place either pillow or bolsters over the patient's chest and then the lumbar region, so as to reduce the lordosis. And prophylactic antibiotic, usually 2 gram of ceftriaxone we are giving as a single shot. I don't extend the course of antibiotics for over like 5 days or 6 days, only a single shot in my practice. Then I would like to show you one of the video. Okay. Okay. Is the video okay? There is some issue. Yes. So video is playing here, but unfortunately it's not able to display on the screen. Is there any control from there you can do? Okay. So the patient's position for this procedure is usually in the prone positions. After proper paint and drape, we usually place the C-arm in a anterior-posterior view, and then we try to square the vertebral body. So suppose if we are doing at dorsal spine or lumbar spine level, like suppose if we are doing this procedure at D12, which is the most common site of metastasis to the spine. Usually we try to do a squaring of vertebra by doing a caudal or cephalic tilt of the C-arm. And also the spinous process that should be in the center. Okay. Then the area of injection for the local anesthetic is the superior lateral position of the pedicle. Okay, so okay, very good. So here you can see this is a like a in the previous. All right. Somehow, actually, because I made this video, so this Movie Editor Pro with this software. So I don't know why this is coming like this. So here we are using a local anesthetic solution. We usually give a nick with the 11 gauge blade, and once we put a good amount of local anesthetic up to the periosteum, we put the Jamshedi needle directly from anterior-posterior side, from anterolateral side of the pedicle towards the midline. Okay, and once we place both of the needles, because the procedure has to be done from the bilateral side. Okay, so one needle, sometimes you have to manipulate your needle because you are checking not only in the AP direction but also in the lateral direction. So if your needle is going any way like superior or maybe inferior towards the foramen, then you have to move your needle so that you directly pass towards through the pedicle into the vertebral body. Okay, and once you put both the needles in the proper place, you remove the stellate, and then you have to use the stellate or the needle introducer itself that goes up to the pedicle, maybe up to the posterior 1/3 of the vertebral body. Okay, so these are the K wires we are using for this procedures. So these are already present in the set itself. So removing the stellate and putting all this guide wire up to the posterior 1/3 of the vertebral body. Okay, so so this is step number 2. Once the guide wire is in place, you try to remove the needle. Just make sure that the guide wire doesn't come out. Otherwise, you have to again repeat a procedure. Then so now take again, because you have to use repeated C-arm in AP and lateral position just to make sure that your guide wire remains inside the posterior 1/3 of the vertebral body. Okay, so again taking a lateral view, so maybe a little bit of hammering is needed to put the guide wire more inside the vertebral body, but never ever go beyond posterior 1/3 of the vertebral body. Once this step is finished, then you have to put the trocar. You have to basically place your trocar over the guide wire and then removing of the guide wire. This is step number 3. Little bit of hammering again at this point of time is needed. Okay, once your trocar is in right place into the posterior 1/3 of the vertebral body, then you have to put the driller. So it has to remove the small bony fragments from that void area or maybe from the vertebral body itself, because vertebral body itself, if it is a metastatic or sometimes in hemangioma patients, basically lot of oozing you will see of the blood, but okay, but this is part of the process. So never ever afraid of if it is not coming like a very gush flow, you are 100% safe, because this is a quite invasive procedure. So both your trocar are in place. You are checking in the lateral view. You see my needle placement there, and this is the driller we are using. Okay, so you use in a screw manner so as to remove the bony fragments in that particular track. Okay, once this step is finished, take out the driller, and then the next part is basically preparation of the kyphon, preparation of the balloon. So once you have to use maybe Omnipack 350 or maybe 300 itself, maybe in diluted form. Sometimes we directly go as a undiluted form. Sometimes we make it like 70 and 30% normal saline. So putting a kyphon inside through this trocar, and then you have to inflate the balloon itself. Okay, so as to create a void or space inside the vertebral body. Now at this point of time, the trocar has to be in the not in the posterior 1/3. It should be in the center or maybe a little bit towards the anterior 1/3 of the vertebral body. Okay. So once you create pressure from here, okay, I mean, from this system, and then you can also see that in the C-arm itself, see here, this area, this is the void, or the balloon is already inflated on this side. And then the other side, again, drilling. And then, because it takes, if you do this procedure, anything from 60 minutes to 90-minute procedure is needed, because we are doing this procedure alone. So it takes this much of time. Then preparation of the cement. Okay, there is already a solution as well as a PMMA cement in the kit itself. So you have to use an appropriate manner. Once the cement is made, prepared, you have to fill in the syringe itself. There are some glass syringe which we are using. Putting those glass syringes in a good amount of concentrated cement, you need to inject the cement directly into these trocars, and you have to use this basically some sort of maneuver, so as to leave not a track of the cement, or not leaving it tail of the cement into the pedicle, or maybe into the skin or muscular plane itself. Okay, so once this solidifies, remove everything, and then just put a 1 or 2 this comes. So procedure is straightforward. Once you are good, like your anatomy is okay, you understand where exactly your needle is. The important thing is, whenever you are injecting a dye through the kyphon, just make sure it is not going into the vascular area, not into the epidural space, not also into the towards the lung. Okay, which is like most dangerous complication for this procedure is pulmonary embolism. Success rate in our practice, 75 to 90% patients get good amount of relief, but immediate pain relief is very, very important, because the thermostatic effect of this cement gives good amount of pain relief. So the patients immediately have good pain relief. Height restoration, because we are using a void as well as kyphon to make a cavity, and filling a good amount of cement, maybe anything from 3 to 5 cc, which is good cement, and yes, significant pain relief. Okay, so we are not going into again the complications. Level of evidence. The first level of evidence for metastatic spine, painful metastatic spine pain is radiotherapy. If the radiotherapy is not working, usually we leave a gap of 2 weeks. Okay, not less than 10 days, 10 days to 2 weeks. So as then only we go for this procedure. Okay, if the patient's suppose metastatic fracture is more than 1 month, okay, you can do vertebroplasty, but kyphoplasty a little bit tricky, because there will be callus formation there. The bone will be a little bit hard because of the natural healing process itself. Okay, and it has to be considered as a level 1 evidence if the pain is incidental. At rest, there is no pain, but whenever the patient try to walk or sit or do change in their positions, it causes too much pain to the patients. So take home message for kyphoplasty: minimally invasive interventions we have done in good number of patients. Immediate pain relief, very, very, like, patients really appreciate. Some of the procedures in pain practice which gives 100% pain relief is, number one this, the other one is trigeminal. Okay, I mean, these are two procedures which gives almost 100% pain relief. The other topic is intrathecal drug delivery system. When the patient is using opioids, and the opioids are not able to give good amount of pain relief, maybe 50%, 60%, patient expectation are high, or there are some side effects because of the opioids. In our practice, we are using oxycodone, morphine, methadone also as a combination of the opioids, but sometimes we have to go for this modality. This modality is very expensive, especially the this totally implantable morphine pump, which is in Indian currency, it's approximately 10 lakh rupees there. if the patient's important thing is, because we are dealing with lung cancer patients, not only lung cancer, we do in all the cancers, but here we are talking about lung cancer patients. The life expectancy has to be more than 3 months, okay, because you are using a device which is very costly, which gives good amount of pain relief with less tolerable side effects, okay. So this is the algorithm we are following for putting an intrathecal or epidural pump. Sometimes we are using a tunneled catheter or portacath also in our practice. So when the pain is refractory, okay, a patient is using morphine more than 200 milligram per day, or oxycodone, or associated side effect with high dose of opioids, life expectancy less than 3 months, we go for the epidural catheter or intrathecal PCA, or sometimes intrathecal catheter tunnel, which is portacath we are using. The life expectancy more than 3 months, somatic or visceral component, single intrathecal trial of morphine, or maybe epidural trial can be given. If it is successful, more than 50% pain relief, go for the implantable device. If it is not, then less than 50%, better try to manage with multimodal analgesics. Contraindications are same almost for all procedures. So this is the tunnel device we used to use when we were in Singapore. Yes, this is for the patient. I remember Jerome patient. Yes, we use this tunnel intrathecal catheter. Okay, and this is the CAD system, PCA pump. In this 1 liter of 0.9% normal saline, we were mixing the morphine, or maybe whatever. Basically, you can use morphine, oxycodone, adding with clonidine. You can add even other adjuvants, analgesics also. So the needle placement is very important. Usually you have to, because we are using a percutaneous approach. We are not surgeons, okay? We are not exploring everything. So with percutaneous technique, like the procedure, how you used to do the epidural catheter placement, the same technique has to be applied here. Once you are in the intrathecal area, basically your CSF will come out, just block that area, put the catheter inside, go inside, and always check with your C-arm where exactly, because the tip of the catheter you can visualize in the C-arm. These are different components. This is the catheter. This is this pump we were using, Trichomed. We have also used Medtronic. So here you're using, this is the area where the lumbar fascia, till lumbar fascia you have to explore, okay? So you have to put a small bit of retractor, and then you have to, once your catheter is inside, there are some butterflies here, okay? So those butterflies has to be tied with the lumbar fascia, and then you have to basically there is a so-called tunneler from which you have to either change a position into the little bit lateral position of the patients, or basically putting your tunneler from here in the subcutaneous plane and then turning in the positions so as you can see the right iliac or left iliac fossa in our because you have to make a pocket in the right side. Here you can see my patient in the lateral position. Okay, this is a catheter. Here I have already draped this area. We have covered this area. So little bit turning this position, maybe making it more supine positions will give you access for this. Okay, this is again you are able to appreciate the this is intrathecal pump itself. Then in the right iliac fossa or maybe left iliac fossa, you can make a pocket here, putting your pump here, and then securing all the connections from this area like this. Okay, this is one of the patients, like lung cancer patient itself. We did in Fortis Hospital, Noida. Important thing is whenever because we have to again remember that dose conversion of opioids. Okay, the oral to intrathecal dose of morphine is 300 milligram of oral morphine is equivalent to 1 milligram of intrathecal with less side effect. Intravenous 100 is to 1, then epidural 20, then intrathecal 1. So this is the dose conversion readily available. The pros and cons of each and every device, like totally implantable pump or CAD catheter, it's a very low cost. Like the CAD system here in India, it costs around 70 to 80,000 if you directly purchase. And basically within 1 lakh rupees, you can manage this CAD with catheter. Otherwise, for intrathecal system, maybe for 4 or 4.5 lakhs rupees for the pump itself, and then the OT and other cost, which is again a lot of burdens if for the patient itself, if the patient is paying from his pocket. Basically, IDDS is a high upfront cost. It has to be basically because refills are very easier, and there are it can go up to maybe few years, not only few months. It can go up to few years. Okay, the chances of infection, because it's a closed system, this is an open system, the chances of infection are high, and here the chances of infection are very less. So the final message, basically, see, remember, I mean, in cancer pain management, the main drug of treatment is morphine, opioids. But apart from opioids, we have to combine the interventions as and when necessary. So going from simple interventions, you have to basically put some sort of tired based approach. Individualize pain management for each and every patient is very important. It's very, very unwise to delay interventions. So especially for palliative care doctors also, it's a important thing to learn at least basics of pain interventions, and whenever necessary, you can refer the patients to the skilled doctor whosoever is doing advanced interventions. Keeping in mind the quality of life for each and every patient is important thing. Okay, thank you very much. Any questions?
Thanks, Dr. Shiv. That was really wonderful. These are the 2 advanced interventions and very painful situations, especially if you are using this intrathecal pumps. It is the refractory cancer pain where we usually take the patients for this type of interventions. And the other one is the metastatic bone pain, where our vertebral augmentation procedures, especially the kyphoplasty, really helps this group of patients. So any questions to be asked?
I think everybody is hungry.
Yeah, I know. We'll take a break. We will have lunch and then we will finish off, or we'll finish it off and have lunch.
How many lectures?
Finish. Okay. We have 1 lecture and then 1 small